In the early 1800s, hospitals grew busier than ever, and that crowding carried a price. After childbirth, some women developed puerperal fever and died within days. After surgery, wounds that seemed fine at first suddenly turned foul, then fatal. Doctors treated what they could see, pain, swelling, heat, but the pattern refused to make sense. The same wards, the same staff, and still the deaths came in waves. The hardest part was that medicine still argued about the cause. Many believed disease floated in bad air, rising from filth and stagnant spaces, so they focused on smells and ventilation. Others suspected something more direct, something that travelled from patient to patient during care, but they lacked a clear target. No one could point to a living germ. Without that idea, even the most careful doctor could spread infection and never know. Hands sat at the centre of this uncertainty. Doctors moved from sickbeds to deliveries and from the dead to the living, using the same fingers to examine, stitch and comfort. Washing existed, but it served cleanliness, not prevention, and it was inconsistent. So the hospital itself became a kind of engine, taking a hidden cause, airborne or carried, and turning it into repeated outbreaks. The question stayed simple, the answer stayed out of reach. In 1847, a young Hungarian doctor named Ignác Semmelweis worked in a Vienna maternity clinic where one fact refused to make sense. Too many new mothers died after childbirth, and the deaths clustered like a chain reaction. Semmelweis tracked the numbers carefully, ward by ward, month by month. Then he focused on what staff did between patients. The pattern pointed back to the caregivers themselves. Semmelweis required something radical for the time. Every doctor and student washed their hands in a chlorinated lime solution before touching patients. It was not a polite suggestion. It was mandatory. Chlorinated lime cut through the stubborn smell and residue left from examinations and procedures, and it forced a new routine into a busy clinic day. The test was simple. If the rule mattered, the deaths had to change. They changed fast. After the hand-washing rule took hold, deaths from childbirth infection dropped dramatically. The clinic went from a place where epidemics seemed inevitable to a place where they could be interrupted. Semmelweis did not need microscopes or a full theory of germs to see the result. The numbers delivered the message. Clean hands stopped a hospital outbreak in its tracks. By the late 1800s, medicine stopped guessing and started testing. A French chemist, Louis Pasteur, showed that tiny living microbes caused fermentation and contamination, and that heat or chemicals could stop them. That idea landed hard in hospitals. Infection no longer looked like fate or bad air. It looked like an invisible opponent that travelled, and once germs had a pathway, hands and instruments became suspects. A British surgeon, Joseph Lister, turned that suspicion into a surgical system. He used antiseptics to treat wounds and clean the field of surgery, and outcomes shifted. Fewer infections followed. The lesson was simple and brutal. Killing germs before they entered the body saved lives. Soon after, a German physician, Robert Koch, tied specific microbes to specific diseases and set lab methods to grow and identify them. The enemy finally had names. With germ theory rising, laboratories and clinics needed chemicals that worked fast and reliably. Alcohol, long used as a solvent for tinctures and a familiar drink, fit the new demand. It evaporated quickly, mixed easily, and could reduce microbial contamination on skin and tools. It became a practical antiseptic you could apply and move on from, not a complicated procedure. Alcohol started changing roles, from ingredient to weapon. By the early 1900s, many hospitals no longer treated hand-washing as a personal habit. It became a rule. Sinks, soap and routines spread through wards, and cleanliness sounded like a problem finally solved. But the reality of daily work tested that confidence. Staff moved quickly from bed to bed, procedure to procedure. Hand-washing took time, and when time disappeared, the practice often disappeared with it. Even when people washed, the method came with a cost. Soap and water scrubbing, repeated dozens of times a shift, damaged skin, hands dried out, cracked and sometimes bled. Those small injuries mattered. They hurt, they slowed people down, and they made the next wash feel worse than the last. A standard had been set, but the body pushed back. Compliance started to look less like discipline and more like endurance. So hospitals faced a new kind of gap. The best-known method did not always fit the pace of care. Leaders wanted something staff actually used, not just something written into policy. The question shifted from whether hands needed cleaning to how to make it realistic, many times a day, without destroying skin. That pressure quietly opened the door to alternatives that promised speed, portability, and less irritation. By the 1960s, hospitals faced a daily contradiction. Staff needed clean hands between one patient and the next, but soap and water routines took time and often got skipped. Researchers tested a simpler idea. Alcohol rubbed directly onto the hands. It sounded almost too easy. But the experiments focused on one hard question. Could a fast rub really cut germs quickly enough to matter? In hospital trials, the results came back blunt. Alcohol wiped out large numbers of bacteria in seconds without the long trip to a sink. When workers used it correctly, the reduction happened fast and repeated well, contact after contact. And something else changed. Because the step was quicker, staff followed it more often. The science and the workflow finally moved in the same direction. That shift created a new concept in infection control. The hand rub. It was not a replacement for every wash, but it fit the real pace of care. It could be used between patient contacts, right when risk was highest and time was tight. The message was clear in practice, even before it was written into policies. Clean hands no longer depended on reaching a sink. By the 1970s, alcohol hand rubs faced a simple, stubborn problem. They worked fast, but they felt awful. The same chemical that stripped germs also stripped skin oils, leaving hands dry, cracked, and sore. And once hands hurt, people hesitated. Hospitals did not need another product that looked good on paper and failed in real life. They needed alcohol that staff could actually tolerate again and again, all day. So the formulation changed. Chemists added humectants, ingredients that pulled water into the outer layer of the skin to counter alcohol's drying effect. Glycerol became a key example because it held moisture and stayed stable in the mix. This was not about comfort for its own sake. It was about keeping hands intact so hand hygiene stayed possible. A rub that protected skin removed a major reason to skip it. At the same time, the alcohol itself became more standardized. Instead of whatever concentration happened to be available, manufacturers and hospitals moved toward known ranges that reliably killed microbes while still evaporating quickly. Consistency mattered. The same dose, the same contact time, the same expected result. Together, moisturizers and controlled alcohol levels changed the identity of the product. Alcohol rubs stopped being harsh lab solutions and became routine clinical tools. In the 1990s, hospitals faced a problem that did not respond to confidence or routine. Antibiotics, once the safety net, failed more often as resistant bacteria spread across countries and between wards. Infections that patients picked up during care became a headline risk, not a quiet complication. The simple act of touching, examining a wound, adjusting a line, moving a patient turned into a high-stakes pathway for germs to travel. Hand washing still mattered, but it collided with reality. Sinks were not always close, soap took time, and busy staff skipped steps. Compliance stayed uneven, and uneven hygiene meant uneven safety. Hospitals started looking for something that fit the pace of modern care without giving up effectiveness. Alcohol-based hand rubs, already proven to work quickly and made gentler for skin, offered a tool that could be used immediately, right where the care happened. What changed in the 1990s was scale and urgency. Infection control teams pushed hand hygiene from a personal habit to a system rule. Alcohol rubs moved from a specialty option into official policy, with expectations for use between patient contacts and after risky tasks. Hospitals placed responsibility on the whole organization, not just individuals. The goal became measurable prevention, fewer transmissions, fewer outbreaks, and fewer infections that no antibiotic could easily fix. In the early 2000s, hand hygiene stopped being just good advice and became an official standard. Major public health bodies put their names behind it. The CDC issued clear recommendations that alcohol-based hand rub worked fast and fit real clinical work. The WHO pushed the same message globally. The wording mattered. In most patient care moments, rubbing with alcohol-based product replaced soap and water as the default. That endorsement changed hospital behavior because it changed hospital systems. Alcohol rub moved out of bottles on counters and into wall-mounted dispensers placed where decisions happened, at the point of care. Staff no longer needed a sink to do the right thing, and hospitals started checking. Compliance audits tracked whether hands were cleaned when they should have been, turning a private habit into a measured safety practice. Training followed, not as a one-time memo, but as repeated instruction tied to specific moments in care. Teams learned when alcohol rub was preferred and when soap and water still mattered. The goal stayed simple. Fewer germs moved from patient to patient. The outcome was bigger. With guidelines, dispensers, auditing and coaching working together, alcohol-based hand rub spread rapidly from policy to routine. In 2020, COVID-19 spread fast and a hospital tool suddenly became a household survival item. People reached for hand sanitizer in supermarkets, offices and pockets, and shelves emptied almost overnight. Demand exploded far beyond what manufacturers had ever planned for. The supply chain buckled. Bottles, pumps, and even the alcohol itself ran short. A simple product turned into a national shortage. To fill the gap, emergency production spread to new places. Distilleries, chemical plants, and small businesses retooled to make sanitizer, sometimes for the first time. Regulators relaxed rules to speed supply while still trying to keep dangerous products out. WHO-style recipes circulated widely, built around specific alcohol levels and small amounts of glycerol and hydrogen peroxide. Speed mattered, but consistency mattered too. As sanitizer flooded the market, the arguments started. Some people expected any gel with a clean smell to work, but effectiveness depended on enough alcohol and proper use. Safety questions followed. Poison control calls rose from accidental swallowing and risky homemade batches, and warnings appeared about contamination and unsafe additives. Online, misinformation spread as quickly as the virus, confusing basic guidance. Sanitizer stayed essential, but trust became fragile. By the time hand sanitizer became an everyday word, alcohol-based hand rub already sat at the center of modern hygiene. It got used without a sink, without waiting, and without excuses. In hospitals, it fit into the seconds between one patient and the next. In schools, it slipped into classroom routines. In travel, it became part of moving through crowds. The simple act turned into a repeated checkpoint. That routine held because the chemistry finally felt settled. People understood that the right alcohol, at the right strength, disrupted germs fast. Better formulations mattered just as much as the alcohol itself. Added moisturizers reduced cracking and soreness, so hands stayed intact and people kept using it. Consistency replaced guesswork. The product worked the same way each time, and the benefit came quickly, right where it was needed. Just as important, infection control became a culture, not a suggestion. Dispensers, training, and expectations shaped behavior until hand rub felt automatic. The contrast with the early 1800s stayed stark. Back then, clinicians faced deadly infections, but lacked germ theory and lacked a reliable, rapid way to disinfect hands in the middle of care. Now the tool existed, the logic made sense, and the habit held.